I'm celebrating our panelists that are coming up on stage. Let's give them a warm applause. Welcome, welcome. And again, our session will be discussing the neuroscience of depression, breakthroughs in brain research. Our panelists, Heather, Harin, Alisha, Alnita, and Dr. Carl are joining us here on stage. We're all mic'd up, and we'll have an extra mic just in case you'll need it.
I am never going to fight out with you.
It's so great to give it to that population.
Oh, shit. So I gave you my card. If you think there's something that particularly if you don't have anything that can lead to financing, that would be just phenomenal.
I'm also interested because I would imagine.
Hi, I'm Heather Gajic, and I
what you spent
am
to
from North
make it.
Carolina. And today I am going to talk about
The benefit if you're trying to make
neurofeedback.
something, and if we can
Do you have hands of
and it's
anyone who's heard of that quantitative brain mapping?
I've been struggling all day trying to put in.
Hello?
I have
Oh,
a grant
here we go.
proposal for the DOD, and you know what's happening.
Okay, sorry, let me put it right here. This morning, I believe it was Dr. Caldwell who said you can't manage something that you can't measure. And how do we objectively measure emotions and motivation, hopelessness? How do we traditionally measure mental health? Client reports, collaboration with treatment teams, family reports, family history, teacher reports, those are all subjective. And QEEG, quantitative EEG brain mapping, is a non-invasive way to measure the electrical activity of the electrical activity of the brain. So we can see if it's hyperactive, hypoactive. We can see if the different regions are communicating effectively, and we can also see if the left and right side are symmetric. So this does not diagnose, but it shows us patterns. So I can have two different clients with the same symptoms of depression, and those outcomes can be very different. Part of that is because research has shown that the people with depression have lower brain activity in the left frontal region. And that is associated with positive emotion, also motivational behavior. And so when you have lower brain activity, then that of course is going to give us some depressive symptoms like low motivation, negative emotion. And so research also shows that depression can show up as very fast activity in the brain in different regions. So the QEEG allows us to be able to individualize care and see really what's going on. It's very cool. And then neurofeedback, you use that, and you can use neurofeedback to train the brain. So it's like physical therapy. It's training the brain in real time. And so we use both of those. Those are definitely alternative treatments. But when you use those and you couple it with collaboration and treating the whole person, it is really exciting.
Hello, everyone. My name is Harin Khalsa. I am a clinically certified hypnotherapist and life coach, and I live in San Diego, California. So I wanted to talk a little bit about how hypnotherapy and depression come together. So a lot of people have, well, actually 70 to 80,000 thoughts a day is what most people have. So many of those thoughts we're not even aware of. And 95% of our operation is coming from our subconscious mind. So depression, which is disrupted brain circuits, which is dysfunction in your amygdala, which is your emotional intensity, and the prefrontal cortex, which is regulating your decision making. So when we have ruminating thoughts that are negative, that is obviously going to cause us to come into depression. Neuroplasticity is central to healing treatments. It can rewire brain circuits, and that's where hypnotherapy also comes in. So when you go into your subconscious patterns and you change them, right? So hypnotherapy, you get relaxed, and we go into, I'm sorry. So going back to rewiring brain circuits. There was a study done by Stanford University with adults diagnosed with major depression and obesity. Antidepressants had a 17% effective rate, comparing to 32% of participants who responded to problem-solving therapy. Their symptom severity decreased by half or more. This is showing us that medication alone obviously is not enough. You have to go to the root of the problem. So many of people that are suffering from depression has to do with trauma and other things that have happened in their lives. And when you actually treat the problem that's causing the depression, instead of just medicating it, your success rate will obviously be much higher. Thank you.
Hello, so my name's Alisha, and I'm a mental health therapist. I own a private practice in Omaha, Nebraska. And so what I'm going to be speaking to today is going to be how depression shows up in the therapy room and the importance of having more of a neuroscience approach to it. And so in my practice, oftentimes people would come in, but they wouldn't identify as being depressed. Because they've seen it as just like sadness. And so what we're learning is that depression is more than just an emotion. So from a neuroscience perspective, depression is no longer just understood as a disorder or even just a chemical imbalance, particularly low serotonin, but it's being more understood as a pattern between the brain and the body and the relationship between the two. And so depression develops as a result of chronic stress, emotional overwhelm, and our early experiences as well as our relational experiences. And so those things impact how the brain and the nervous system start to communicate with one another. It also affects how we think, it affects how we feel, the emotions we may find ourselves experiencing more often than not, and also how you learn to respond to things. So there are a few key brain networks that are involved. So the first one is called the default mode network. And so this one is, when it's active, it's about the mind turning itself inward. And so it helps to support self-reflection, meaning making, recalling past memories. But in depression, it becomes overactive. And so what it leads to is rumination, self-criticism, and repetitive negative thinking. So the next network that is involved is called the salience network. And this one involves primarily the amygdala as well as the anterior cingulate cortex. And so the best way to think about it is it helps with threat detection. So it helps us to determine what is important and meaningful. So when it's in depression, it becomes more biased towards negative information, making you more likely to interpret neutral events as negative or threatening. And then the third brain network that is impacted is the executive functioning, which has been mentioned a lot today, which is located primarily in the prefrontal cortex. So that's the part of the brain that assists with decision making, emotional regulation, impulse control, perspective taking. And so in depression, the executive functioning becomes underactive. So what that essentially means is it makes it harder for people to regulate their thoughts and feelings. It makes it harder for them to shift perspectives, and it makes it hard to interrupt rumination. So basically what you start to see in the brain is you have a brain that's over processing negative information while being under supported in regulation. And from a neuroscience perspective, I'm just going to say, if you guys can tell, I'm a little nervous. So I'm talking about the dorsal vagal, but I'm actually experiencing more of a sympathetic state. So please bear with me. So at the same time that these brain networks are being impacted, it's also showing up in your nervous system. And so in depression, looking at it from a physiological perspective, your body is basically in a shutdown mode. So that means that it's in conservation, where when you look at the stress response, it's more correlated with the freeze response. Essentially, like your body being left for dead, this is kind of the last opportunity that your body has to protect the organism. And so what that means is it starts to conserve energy. And so the energy output starts to get reduced as a way to conserve. So the way that starts to manifest from a body perspective is you become fatigued, you have difficulty concentrating, low motivation, hopelessness, helplessness. People may experience shutdown. Your senses become a bit more dulled. So what that suggests is that depression is not just a mind disorder, but it's also something that's impacting in the body. So what that essentially, why that becomes beneficial is in my practice, I would see people who would identify with depression as more of a mental disorder, and that comes with a lot of negative stigma. So being able to provide this perspective of just how their body is going into a protective response because it's responding to the painful events that it has experienced, it allows people to look at their presentation and what they're dealing with in a more compassionate and curious way, and understanding like how things are showing up and manifesting today is not because something is wrong with me, but it's the way that my body has learned to adapt and adjust to what I've experienced. And so due to neuroplasticity, as a lot of people have already talked about today, it means that the brain and the nervous system can be rewired. And in my practice, what I have learned is an integrative approach is best. So you are treating the mind, but you're also treating the body as well. So using body-based practices that increase people's ability of interoception, and that's just the body's ability to sense what's happening internally, which leads to better emotional regulation. Because if you can sense when your heart rate is increasing, when your breath rate has changed, when your body is a little shaky, that becomes information that allows you to better regulate your emotions. Also, trauma-informed treatments such as EMDR that can really assist in challenging core beliefs. And then also relational therapy, because our nervous system is the house of our lived experiences. So when you've had attachment and trauma, as we heard about today, that gets stored in your nervous system and your body remembers those experiences. So therapy, when you're in a safe and supportive relationship, can provide a corrective experience to what you may have not experienced in the past. And lastly, what is also helping to assist in neuroplasticity is treatments that are emerging, such as psychedelic assisted supports and ketamine. So what they do is they help to disrupt rigid patterns in the brain. And so it creates an opening for neuroplasticity to really exist. And then that's where ongoing treatment can really be more integrative and more sustainable, increasing people's emotional capacity. Thank you.
Good evening, everyone. My name is Elnita Adi. I'm a licensed clinical mental health counselor in North Carolina. And I provide trauma-informed care to my clients. What I find in treating depression, one of the key factors is developing that relationship with your clients. A lot of my clients, whenever they come in with the belief that there is something wrong with them. They believe that they are inherently flawed because they don't have energy, because they can't get out of bed, because they don't feel, because a lot of them are disconnected and lose time. So they believe that there's something inherently wrong with them. And so in my work with treating depression, my focus is on first teaching my client about their nervous system, teaching them about being in survival mode, because a lot of us are stuck in survival mode and we don't know it. And so just having that information, learning about hyperarousal, hypoarousal, about being within that window of tolerance and being regulated, having that information is powerful, because my clients are able to learn that, okay, I have these three states. I'm in hyperarousal, which is fight or flight. The window of tolerance is green, and that is when I am calm and relaxed and I'm able to access reason and logic. Or I'm in hypoarousal, which is freeze. So learning that, okay, I'm in one of these three states at all times, and I can learn skills and resources that can help me go from fight or flight into that window of tolerance, or from freeze into the window of tolerance. So in the beginning of my work, that is what we focus on. I focus on teaching my clients about the window of tolerance, about the three states of our nervous system, and teaching them the skills and resources to change their states. So what I'm teaching them is this: you have the power within yourself to change how you feel. That you do not have to allow, depression doesn't have to control you. You can learn to manage and control depression. So how do I do that? I just told you I teach them about the nervous system, about the three states and how you can move between those three states. And I'm an EMDR therapist, so I teach my clients regulation skills. I teach them how to regulate themselves. I teach them to be in tune with their bodies, because a lot of people are not in tune with their bodies. So by teaching my clients about the nervous system and about the regulation skills and using EMDR therapy, I'm teaching them that all of the skills, having no energy, being shut down, not being in touch with what's going on around you, that those are survival skills. They're maladaptive survival skills, but they are survival skills. The skills that I'm teaching you are adaptive, and you get to choose, my clients get to choose on a case-by-case basis which skills they use. Do you want to use the adaptive skills, or do you want to use the maladaptive skills? Because if I'm teaching them that the skills that they've used, they helped you. They help you for a lot of people, those skills help them to survive traumatic childhoods. So I'm not taking away the old maladaptive skills, but I'm teaching them new skills, and also teaching them that they have a choice and they get to decide which skills they use. And what I find is that over time, learning the skills, and when I teach the skills, I don't just tell them what to do. We use the skills in session, and then their homework is to go back and use the skills in their everyday life. And my clients who have the best progress are the clients who internalize the skills and use them in their everyday lives. And by learning these skills and using them, they're able to change their brains, rewire their brains. Alisha, Ms. Nutt, she mentioned neuroplasticity. So being able to change your brain and be able to change the way that you have historically responded to things, and you're able to go through life using reason and logic instead of using those old maladaptive survival skills. Thank you.
Good job.
Good afternoon. My name is Dr. Carl Forkner. I'm a research psychologist. Very specific reason why I'm a research psychologist. I don't do clinical because I have enough problems of my own. I don't need everybody else's. I first got involved with neuroscience and neurofeedback about 9, 10, 12 years ago. And 8 years ago, we did a study with 50 veterans that worked for a Fortune 500 company, which I'm not allowed to give the name out, to see if there was a way to help with their transition from military to civilian life and the issues that they brought with them from trauma that they may have received during their military career. What we did is, first, we decided, how are we going to measure this? Because we had to have a measurement instrument. So we used the PCLC, the PTSD checklist civilian for measuring PTSD effects. We used the Comprehensive Executive Function Inventory Adult, which examines 9 areas of executive functioning, and the World Health Organization Quality of Life Brief, which measures 5 integrated areas affecting quality of life. We use neurofeedback as a primary tool, along with a set of supplements to ensure that everybody in the study was getting the same dose of the right kinds of vitamins, minerals, etc., making the assumption, because every study has an assumption, right? Making the assumption that they were taking them the way they were supposed to. This study went on for 6 months, and we saw each of those clients on a weekly basis. At the end, we found that they had a 30% improvement overall to their quality of life, an overall 17% improvement in executive functioning, and a 73% reduction in the impact of trauma. Now, I have a very specialized niche, and that is veterans. I've been a veteran service officer for 8 years. I focus most of my research with veterans, and sometimes I find myself laying on the floor with a veteran curled up in the fetal position crying, talking to them to help them out of what they're going through. Until firefighters and policemen, and later nurses, had problems with PTSD. And in fact, policemen and firemen lose more members to suicide than they do to line of duty deaths. Suicide didn't really come as a big capitalized bold letter issue. Well, what we do to help with neurofeedback, as well as getting to know the client, is to balance the brain, the alpha, beta, and delta waves. Help them get back to where they're supposed to be, to function effectively. And then we follow up. In the study, we followed up at the 6, 12, 18, and 24-month period to do a comprehensive evaluation at each of those points. What I do now, I just finished a study over the last year that is going to be out in a book, which I won't promote yet because it'll be out sometime this year, called Beyond the Diagnosis: Why 60% of veterans who complete treatment still suffer with PTSD, and the moral injury tools that can help fix that. Because we look at things typically in the medical profession, and sometimes at points in the psychological profession, that have clear diagnostic tools. You can say, okay, this fits here, and so forth, like in the DSM-5 for PTSD. Moral injury does not have a diagnostic tool. Nobody has yet been able to decide what that is. So it's hard to develop a specific checklist treatment for that, or a specific equipment assisted treatment for that, because every case is wholly individual. But in the study I just finished, literally 99% of the veterans with PTSD also had moral injury. And by not addressing that, we're not fully addressing their PTSD, which means PTSD also includes some of the things that they spoke about: hyperattention, hyper alertness, being always on guard, fight, flight, or freeze, depression, anxiety, self-isolation. All of those things go with it. So what we're doing now is we have a new experiment going on that we can measure with some of the same tools that we measured our 2018 study, and that is bringing together ministry professionals with psychological mental health professionals to co-treat or cooperatively treat patients that are veterans who have PTSD, to try to help with the whole problem, not just part of the problem. So thank you very much. We're losing more than one veteran an hour to suicide and one active duty service member a day. And that's not counting the family members who commit suicide. So it's a problem, and it's something that Senator Blumenthal mentioned on the floor of Congress. He said, words without action are meaningless. We hear a lot of talk. We've spent tens of millions of dollars over the last 3 decades, and we haven't come up with a solution. We hear some of these treatment regimens that these professionals are using that can be very, very effective. And the reason they can be very effective is because, as they mentioned, you have to treat each patient as an individual, because everybody's life is different. So thank you very much, and on to the awards. What a time for the MC to not be here. I'm used to shouting across the flight deck, so I don't really need a mic.
Does anybody have questions?
Yeah, questions? We only have an hour
question. I
left.
got you right over here.
I do coaching leadership training, and I'm also a breathwork facilitator, diaphragmatic breathwork, which directly impacts trauma and helps reduce stress and toxins, etc. How are each of you handling bringing breathwork in, because scientifically it's proven as a way for depression, releasing depression? So we're talking about EMDR, but breathwork is directly in your body and easy to access. And I didn't hear any of you mention anything about breathwork.
Absolutely.
I work with veterans too.
One of the things that can help to calm my clients when I see them is to do breath work, and that helps them with mindfulness and understanding what's going on within themselves. Yeah.
And I will add with QEG and neurofeedback. Biofeedback is a really important piece of that. And so when you do neurofeedback, you can have heart rate variability, there's breath belts. And so when you take all of those and put them together, it's super important. I'm glad you brought that up, because the biofeedback part is what they need to know to calm that fight or flight.
Mm-hmm.
And they need to know, where is it starting, and, what thoughts are causing them to go into fight or flight and release all those stress chemicals. So that is super important.
I have a question. I am a mental health care therapist with a private practice, and I specialize in trauma as well. And I do brain spotting. Do you recognize brain spotting as a trauma-informed treatment?
Okay, yeah. So I wanted to still speak to her question as well, and I will answer yours as well. So I'm a breathwork facilitator. I'm a registered yoga therapist, sound healer, meditation. So I do integrate all of those holistic practices, primarily when it comes to depression, because your energy, as I talked about, is in a shut down state. So there are only certain breathwork practices that you really want to do that help to really increase the flow of energy. Whereas if someone was experiencing anxiety or they were in fight or flight, in a sympathetic state, you are trying to ground. So I do incorporate those things depending upon the client's needs. And then I am trained in brain spotting as well. While it's not an evidence-based practice, I have seen it be very successful, because what brain spotting can help with is, when I talked about interoception, that it helps people to be able to sense what's happening internally. Brain spotting is really increasing that bodily awareness, making people more aware of the sensations that are happening in their body as they're processing experiences in their mind. So that's increasing the mind-body connection, which you're ultimately trying to establish.
We have one more question this way.
Crackling. So I work with clients that have done neurofeedback, and I've seen the benefits of that. And how many of you worked with accelerated resolution therapy instead of just on EMDR? Because it does do the bilateral, and in connection with neurofeedback has done tremendous work. And also with the breath work, I do that with the holistic part, where introducing that maintenance afterwards just to keep the regulating. So how many of you actually do the simplicity of choosing the coping skill where it can be activated in less than 20 seconds with the breath work?
I haven't done any of that in my research.
Could you repeat the end of your question, please?
Trying to remember what I said.
Can you repeat the end of your question,
Yeah,
please?
I'm trying to remember what I said. So
Oh.
how many of you are using the breath work to help with the maintenance part, to help regulate, even though the neurofeedback helps retrain the body, the nervous system, and like physical therapy really is great with it, but the maintenance part, that holistic component of it.
Okay. Maintenance part. I'm not trained. I'm not a breath work. I'm not trained in breath work. As far as maintenance, the skills that I teach my clients, what my focus is, if you don't use this, if you only use this when you're with me, it's not going to be effective. What is going to help you the most is what you do in your everyday life. So homework for me is always to use your skills. Use your tapping every day, breathing every day, focusing on your breathing. So that is the maintenance, because what the goal is for the word is gone now, but it's to integrate the skills into your everyday life. I teach, so breathing, in my sessions, whenever my clients become dysregulated, the first thing I'm going to do is say, breathe. Take 5 breaths, take 5 more. I use essential oils like lavender, lemongrass. I keep the oils in my office, and I allow my clients to choose an oil. And if you use that on a consistent basis, whenever you become dysregulated, just breathing your lemongrass, it is going to help your nervous system to calm down. I use lemongrass as my scent. I tell my clients know that you might open your eyes one day and see me breathing my lemongrass, because I hear a lot of tough stories every day. So I use lemongrass, and I teach my clients that the same skills that I'm teaching you, that I use them myself, and that usually helps motivate them to use the skills as well. So that's what I do for maintenance, is that your homework is to always use your skills, and that my clients who have the most success are the clients who integrate the skills into their everyday lives. I hope I answered the question. Thank you.
We're going to answer one more question before we wrap up and proceed for the recognition for the night.
Okay, there are 2 quick questions. First, the two ladies in the middle, are you licensed to practice in the pink and the white next to each other? Are you two licensed to practice in the state of Nevada?
No.
Crap. Okay. Other question. For the doctor who did the clinical studies, is there a test or something that can be requested that tests executive function?
Yes, there is. The CEFIA, the Executive Function Assessment in Inventory Adult, is an exploration of executive functions across 9 areas.
And I'd like to add to that. With the brain mapping, we can see patterns that are related to executive functioning deficits. And as far as the breath work, I think that it's so important in the beginning for psychoeducation, which was talked about, and learning how to use those methods to calm the body down. I have an interesting case to where I did the brain mapping, so I was able to see which part of the brain we were inhibiting the brain waves and working on. And she was a yoga instructor, and so she was really used to just finding that breath and all of those skills. And when I was doing neurofeedback, I was able to see that when she closed her eyes, because it's 10 minutes eyes open, 10 minutes eyes closed, so you can see like what happens when your eyes are closed in real time, what the brain's doing, and then when you have the external stimulus. But she actually started to get very, very anxious when she tried to go into that like calm state. And it was because, so we were able to see that her brain patterns indicated that they started to get faster. And so what she really had to do was not get in that state in order to learn to calm her body down. So it's very interesting, all of it. And I think that for like first responders, there are patterns where their brain actually does not transition into the state of eyes closed. And that's because they're trained to, be awake, be aware. And I think it's important, like for neurofeedback, we don't want to train that. We want them to have that. So that's where the QEEG, the brain mapping, can help. So we can really individualize treatment.
Thank you so much, panelists, for sharing your expertise, your insights, and for sharing your vulnerable bravery here on the stage. For being real, even when in real time we're talking about these conditions, not even conditions, these ways that show up in our life, to have the courage to say it's happening in real time, that's amazing. I have so much respect for all of you on the panel. Thank you. Please give them one more round of applause. Thank you again.